Hi, thanks for joining us. I'm Jerry Giesbrecht, and along with my postdoctoral fellow Elnaz, Vaghef, Mehrabani, I'll tell you about our work looking at whether maternal choline intake and DHA status can moderate the effects of adverse childhood experiences on maternal and fetal stress response systems. Stress is a whole body response that can change the way we interact with nutrients. For example, stress can change signaling pathways between the gut and brain, leading to either increased or decreased eating. Stress can also shift eating patterns toward calorie-rich and fatty foods that are low in many essential nutrients. Stress can also exaggerate poor diet choices by increasing inflammation in response to diets that are high in sugar, refined starches, and saturated fat. But the relationship between stress and food is a two-way street. Suboptimal nutrient intake can also exacerbate experiences of stress. One of the ways nutrients can make stress worse is by increasing stress reactivity. For example, by increasing cortisol production to a level that causes wear and tear on our tissues. Diets high in fat and sugar have pro-inflammatory potential, which can increase susceptibility to stress-related conditions such as anxiety and depression. Nutrients can also affect availability of neurotransmitters, which are also related to anxiety and depression. We also know that this dynamic interplay between stress and nutrition plays out in the maternal placental fetal unit. On the left side of this figure, you see the maternal hypothalamic pituitary adrenal axis, which is the main stress response system. The main product of this system is cortisol. During pregnancy, the placenta becomes an additional endocrine organ that stimulates the maternal HPA axis. But the placenta also protects the fetus from maternal cortisol by metabolizing some of the cortisol as it passes through the placenta. But this protection can be altered by nutrients. For example, high-fat and low-protein diets tend to reduce the placenta's ability to protect the fetus from maternal experiences of stress and cortisol. And of course, we know that the experiences that mom has and the food she eats are incorporated into the baby's developmental outcomes. This led us to wonder whether nutrients could buffer the effects of stress. We know from the work that I just reviewed that there is a relationship between stress and nutrients. But we wanted to take it a bit further to explore whether nutrients can actually dampen the stress response, and in so doing, minimize the effects of stress on pregnant women and their children. My lab had already been working on the idea that it is possible to block the effects of stress using social relationships. Specifically, we looked at the ways that a supportive partner could dampen the cortisol stress response system. So what you see here in the yellow is that pregnant women with high social support had very little increase in cortisol following a stressor, but women with low social support, the red line, had large increases in cortisol. We wondered if these effects would extend to adverse childhood experiences, things like abuse and neglect that the mother experienced during her own childhood. We had previously shown that adverse childhood experiences amplify stress responses in pregnant women, which you can see here in the gray line. This figure shows the change in cortisol production over the course of a typical day, and the higher gray line indicates overall higher cortisol production in women with a history of adverse childhood experiences. It doesn't look like a huge difference, but even small changes in total cortisol production can have significant effects on brain and behavior. So the next question we wanted to ask is whether social support acts as a buffer that could essentially protect the baby from the maternal stress response. What we found is that among families characterized by low social support, and again in this study it was support from the partner, adverse childhood experiences resulted in increased maternal cortisol, and this subsequently led to increased infant stress reactivity. But among families characterized by adequate social support, this intergenerational cascade was blocked, and we no longer could see any effects of maternal adverse childhood experiences on infant stress reactivity. These findings for the buffering effects of social support made us think that there may be other factors, including nutrition, that could also have a buffering effect. Now I will hand the remainder of the presentation over to Dr. Vaghef Mehrabani.
Hi, thank you for being with us. As Dr. Giesbrecht mentioned, adverse childhood experiences, ACEs, induce hyperactivation of maternal HPA axis during pregnancy, which can in turn affect HPA axis function in the offspring. Dietary factors might buffer these detrimental effects to some extent. We aimed to look at the moderating role of choline and docosahexaenoic acid DHA in the current study. Choline is a vitamin-like nutrient with higher concentrations in animal-based foods. DHA is an entry fatty acid mainly found in seafood and fortified products. Results from animal studies and clinical trials suggest that higher choline intake is associated with decreased placental corticotropin-releasing hormone (CRH) expression. Placental CRH forms a feed-forward loop with maternal cortisol, which under normal conditions is essential for proper fetal development. However, subsequent to ACEs and under chronic maternal stress, this loop results in disproportionately high fetal exposure to cortisol and unfavorable neurodevelopmental outcomes. Entry fatty acids are well known for their anti-inflammatory effects in the body. Inflammation downregulates the placental enzyme 11-beta-hydroxysteroid dehydrogenase type 2. 11-beta-HST2 converts cortisol to its inactive metabolite cortisone, thereby protecting the fetus from high cortisol exposure. Entry fatty acids are postulated to enhance 11-beta-HST2 activity by hampering inflammation. Improving glucocorticoid receptor signaling pathway is one other mechanism through which entry fatty acids might prevent HPA axis hyperactivity. Therefore, we hypothesized that 1. Prenatal choline intake and prenatal DHA status buffer the effects of maternal ACEs on prenatal HPA axis function, and 2. They moderate the effects of prenatal HPA axis function on infant HPA axis function. Here is the directed acyclic graph DAG for our study, which illustrates the moderating role of choline intake and DHA status. Other variables that can affect the outcomes are also presented in this DAG. Socioeconomic status, SES, prenatal psychological distress, diet quality, maternal age, and parity are factors that have an impact on maternal HPA axis function. SES, prenatal diet quality, postnatal psychological distress, gestational age at birth, prenatal perceived demands, and prenatal stressful events can influence infant HPA axis reactivity. These factors were added to study models as covariates. Our study included 356 women and 236 3-month-old infants from the APrON study. Study assessments were performed at T1, 6 to 26 weeks of gestation, T2, 27 to 37 weeks of gestation, and T3, 3 months postpartum. ACEs and psychological distress were assessed using valid questionnaires. Saliva samples were collected from mothers and infants. Cortisol awakening response, CAR, and total daytime cortisol were measured for mothers, and average cortisol levels as well as cortisol reactivity were the outcomes of interest for the infants. Maternal choline intake was estimated using 24-hour recall at T1 and T2. Maternal DHA was measured in serum samples using gas liquid chromatography technique at T1 and T2. Multi-level modeling was used to analyze data. Our results showed that choline intake does moderate the association between ACEs and CAR during pregnancy. As the figure shows, in women with 4 or more ACEs, higher choline intake was associated with lower CAR. This effect was not observed in women with no ACEs. We found no buffering effect of maternal choline intake on the association between ACEs and total daytime cortisol. There was a significant positive association between gestational week and both CAR and total daytime cortisol in our analyses, which reflected the expected increase in cortisol as a function of advancing gestation. Choline intake, when added to this model, did not moderate the association between ACEs and change in HPA axis function. Our analyses with DHA status revealed no buffering effect of DHA on the association between ACEs and neither CAR nor total daytime cortisol. As for choline intake, DHA status also could not moderate the association between ACEs and change in cortisol as a function of advancing gestation. Running the analyses for AIM-2 of our study, the results showed that choline intake can buffer the association between maternal CAR and average infant cortisol levels. In mothers with low choline intake, higher CAR was associated with higher infant cortisol. This association was not observed in women with high prenatal choline intake. Maternal total daytime cortisol was positively associated with infant cortisol. This effect was not buffered by choline, though. The results didn't differ by infant sex. When time was added to the model to determine the effects of maternal choline intake on the association between either maternal CAR or total daytime cortisol and infant cortisol reactivity, no significant results were obtained. According to our analyses, maternal prenatal DHA status did not moderate the association between maternal prenatal CAR or total daytime cortisol and infant cortisol or cortisol reactivity. No sex effects were observed either. In summary, prenatal choline intake, but not DHA status, could buffer the effects of maternal ACEs on maternal CAR but not total daytime cortisol. And again, prenatal choline intake, but not DHA status, could moderate the effects of maternal CAR but not total daytime cortisol on infant average cortisol but not cortisol reactivity. Further studies are required to elaborate these results. Thank you very much for your attention. Any questions?